Assalamu alaikum wa rahmatullahi wa barakatuh, hello everyone. Today, inshallah, we're going to answer some EMQs regarding gynae. And I know that you have covered some topics with Dr. Rabah. So I'm going to continue from where she stopped. We are going to answer some questions today. I love this book, honestly. So as you can see, we are having a question regarding amenorrhea, which is very common in your exam. You have to have at least one or two questions regarding amenorrhea, or amenorrhea with infertility, or amenorrhea with sexual disorders. So it could be like a mix. Who knows? So let's see. We are having here a lady. She's 44. By the way, the age is important. Okay? How far she is amenorrheic is important. And also, whether she is seeking fertility or not is important. So let's see. Here, the woman is 44. Okay? Present with 4 months being amenorrheic. She also complained of easy fatigability. Okay, so we have some signs and symptoms. Excellent. She gives a history of 6 months amenorrhea 15 months ago. So yeah, she's having irregular periods somehow. When she was investigated and discharged with normal results, her GP had organized blood tests which showed normal LH and FSH. Raised prolactin, we need to highlight this, and normal testosterone and sex hormone binding globulin. So I have excluded the causes of hyperandrogenemia as the possible cause of this amenorrhea, right? Okay. She had a borderline raised TSH and thyroxine. What is the next appropriate investigation? Choose one of those. The best way to crack an EMQ is to have the answer already in your head and search for it within the options. And if you find something better than what you are thinking about, you have to highlight it. And if you ended up with 2 or 3 options, we are going to choose between them. Choose the best of them. Okay, Dr. Sarah, definitely. We can have some questions regarding menopause and when to stop contraception. عيني حاضر. Okay. So I'm having some of you saying that I need to do a pregnancy test first. Some of you went for another idea. They want to do visual field examination. I have a short memory. Does this woman have any high prolactin levels? Why you want to do a visual examination? Am I missing something? There is raised prolactin? Okay, there is raised prolactin, okay. And there is also borderline raised TSH and thyroxine, okay. So I have highlighted both of them. What do you think the next appropriate investigation? And the idea now is to correct our concepts, okay? It's not like we are answering questions and the question and the answer, we are not going to recall it like this in the exam. We need to think how to crack such a question, and it's a very easy one, by the way, but it needs structured thinking. The thing that is worrying me a lot is that you are having different answers, totally different answers, totally different approaches to the question. عليكم السلام ورحمة الله. عليكم السلام, dear. Okay, so I need you to tell me why you are thinking of that the best next one is going to be CT or visual defects. By the way, they didn't tell us any numbers about the prolactin, just raised, just like this, very general term. So do you think that this is the best one to be done next? Simply, guys, simply, they didn't say anything about her sexuality, whether she is sexually active or not. They didn't tell us anything about exclusion of pregnancy. The best next or appropriate investigation medico-legally is to exclude pregnancy. Simply, why this patient is not pregnant? Before going through any management, or even if you are thinking about thyroid, even if you are thinking about prolactin, how I would know that she's not pregnant? No, 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 not 15 months of amenorrhea. No, she gives a history of 6 months of amenorrhea 15 months ago. Now she present with 4 months of amenorrhea. So right now, it's only 4 months of amenorrhea. Anyway, even if she's not pregnant, I need to exclude pregnancy. Simply. Yeah, it happens. It happens. Have a look. Okay, you know why I'm sure that she is going to need a pregnancy test? You know how? How I know? One of you said I need to go through hyperprolactinemia investigation. And one of you said, I want to make sure about her visual fields. One of you said, I want to go through with thyroid function testing and make sure that she's having a problem with the thyroid. When we have different management lines like this, none of them is correct. Because all of them need to be done. All of them need to be done. Yes, you are right. I need to make sure that she is not having a visual field problem. From the history, by the way, if she's saying, no, I don't have a hemianopia or darkness in my fields or anything like that, or blurry vision, that's fine. We are not going to order the visual field examination, by the way. And we don't need to go for a CT if she's not having headache or any neurological symptoms. This is another thing. Okay, talking about hyperprolactinemia. If this woman is having prolactin 2000, let's say she's having 2000, are we going for a surgery, or what would be your first line of management? No, who said so? Early pregnancy can raise prolactin. Why not? And this is not the idea. The idea is to exclude pregnancy anyway. Yes, the first line management for high prolactin is medical, guys. It's always medical unless the patient is having pressure symptoms. If she's having pressure symptoms or neurological symptoms, okay, I'm going to order the CT. Otherwise, CT is not of your initial investigations. So simply this woman need to have the pregnancy excluded. Simply. Okay? Agree? Let's have the second one. She's 25. 6 months of secondary amenorrhea. Okay, so they are being specific here. Her height is 10 centimeter below her mid-parental height. Okay, so she's short. Okay, and she is not like familially short. She's so short. Anyway, see here, negative pregnancy test. This is very important. She started menarche at 18 years of age. She's noted to have a short neck, wide carrying angle. Do you have a diagnosis? Possible one. Yeah, she could be Turner. What kind of Turner? She's not any kind of Turner. Mosaic Turner, excellent. She could be mosaic Turner. So what is the most relevant? See the head of the question. What is the most relevant investigation to establish the diagnosis? I'm not looking for her health problem here. I'm looking for something to help me diagnose her as a Turner. See, now when you understand the question, it's going to be very easy. Right? Karyotyping, excellent. See, very easy one. Very, very easy one, because they didn't ask me here, what would you do regarding her infertility, for example? Or they didn't mention something about hormonal profile. No, I want something to establish the diagnosis. We suspect that she is Turner. Okay, but by the way, she could be normal. And she could be short because of this is something familial. She could be having a short neck genetically. Okay, but theoretically speaking, when I'm having all those together, I need to exclude Turner first. Excellent. Okay, this lady here, she is 23. Yeah, this is why I'm telling you the head of the question is really important. Really important. You need something to establish the diagnosis. Hormonal profile is not going to help you with this. Okay, she's 23. The first one, pregnancy test. This one, karyotyping. The third one is 23, 8 months of amenorrhea, excessive hair loss, appearance of facial hair. Up to here. Up to here. When I'm having a woman who is losing hair, and if they told me that this is the male pattern hair loss, they make it very obvious. With appearance of facial hair, those are symptoms of what? Not really PCO. I don't know yet. We have a more general term for this. PCO is one of the differential diagnoses. Excess androgen, hyperandrogenism. Excellent. This could be hyperandrogenism. And she is now, guys, like a male. She could be having a male pattern baldness, excessive facial hair, hair in the chest, up to virilization. She could be having change in her voice, muscle bulk, clitoromegaly. Okay, so we have hyperandrogenism, which could be only hirsutism or up to virilization. Let's see. 2 months previously, there had been bereavement in the family. Okay. She has a negative pregnancy test, which is very important for me. What is the most appropriate investigation? If you have to choose something from here, androgen free index is the best. Is it there? Do we have androgen free index? Yeah, we have it. Option B. And we have testosterone and sex hormone binding globulin, which, by the way, I can use them to have a free androgen index. But option B, by the way, is not only free androgen index, it has also LH and FSH. Actually, I'm conflicted. I'm not going to lie to you, but here we are in one of the problems in our exam. I have two options. Both of them work, and I need to think about which one is more appropriate. So let's think about it. Is there any benefit from the LH and FSH here? Do you think it's going to help? If yes, tell me how. I'm really happy that you say so. And let me remind you that we don't use FSH and LH ratio for diagnosing PCO. Can anyone remind me, please, how we diagnose PCO? The Rotterdam criteria. Excellent. So we are not going to depend on the LH-FSH ratio. You know, guys, when should we order hormonal profile? When should we do this? When you are having a normal female. When you are having a normal female and there is no red flags about anything like hirsutism or ovarian problem, I mean mass, okay, or cyst or something like this. Okay, what I can order now is the hormonal profile to make sure that this woman is ovulating. This is why we do the hormonal profile. The FSH at the follicular phase and the LH in the luteal phase can help me out. See if this woman is ovulating or not. She could be amenorrheic for no reason, idiopathic. And her main problem now, for example, is fertility. So I want to make sure that she is ovulating or not. But hormonal profile in such case is not going to help you by any means. Excellent, Dr. Arwa, to test for one of the investigations for premature ovarian insufficiency. One of them, because in POI, I'm making a picture, and this picture is like a puzzle, and I'm getting a piece from here, getting a piece from there. I need to do AMH. I need to do follicular count. I need to observe the ovulation, do hormonal profile, all together to know whether this woman is losing her ovarian count or not. So again, back to the exam. I am conflicted between two choices, right? And I don't know which one of them is correct. By the way, this is very common in your exam. Very common. You can be conflicted with not only two, it could be three. But if we are conflicted between two, we are amazing, by the way. Now let's think which one is better. I want to go for the free androgen index, but I'm not really sure about this one. And here there is testosterone and sex hormone binding globulin. They are very useful for me. Very useful, especially this. You know why, guys, we do the free androgen index? Why we do it? Because it contains the sex hormone binding globulin. You know that many women could be having slightly or borderline normal testosterone, but their main problem is in the binding globulin. PCO. PCO could be having normal testosterone, but she is having low binding globulin. So the testosterone is free. It's circulating in the system. No one is bounding them. I'm not chained. I can go to the cells. I can act on the receptors. Even if my levels are not so high, but I'm free. Normally, in any female, we have only 1% of the testosterone in our system free. When you're having a low sex hormone binding globulin levels, you are going to have very active testosterone, even if they are in normal values. Okay, so yeah, this is really important, especially for PCO, especially. I wish if we are having other questions for amenorrhea here. If not, I'm going to open another file. Let me see. Yeah, we have the first one. Okay. This 19 years old girl present with recent onset facial hair growth. Recent. Okay, this is important also. 4 months history of secondary amenorrhea. Investigations by the GP showed a negative pregnancy test. Thank you. Normal hormonal profile, thyroid function, pelvic ultrasound, and the blood glucose also. The serum androgen was elevated. What would be the next appropriate test? Let me get you back to this. They said the serum androgen was elevated. So now I'm trying to light up some bulbs in your brain. I reach it in the algorithm now, a diagnosis of hyperandrogenism. But do I know what is the cause of this hyperandrogenism? I don't know. It could be adrenal. It could be ovarian. I don't know. So what should I do next? This is how you should think about it, guys. Now I have a case of hyperandrogenism. What should be done next? Here, they didn't mention the ultrasound, but the ultrasound is very important in such case because it can give me an idea if this is adrenal problem or ovarian problem. Ultrasound is done. So, wallahi, see, wallahi, I had my, yeah, the pelvic ultrasound is done. I had my coffee, but I'm just like someone in the exam because I didn't highlight it. Yeah, attention deficiency. Yeah, they said the ultrasound is normal. Okay, so we excluded masses. So far, we excluded masses. So what do you think the best investigation that could tell me if this is adrenal or ovarian problem? J, and yes, you are correct. The ACTH or synectin test. Yes. Actually, we don't really need the DHEA because we already have high androgens. DHEA can help us if you are still in doubt. If you are still in doubt. Okay. So amazing, guys, wallahi, amazing. So shall we have a look over the algorithm for hyperandrogenism? Okay, so I had a question which is amazing one. If there is ACTH test and synactin test between the choices, which one is the correct one? Synactin, of course. There is a huge difference between both of them. ACTH test is you are investigating the levels of ACTH. Synactin test is giving ACTH a shot, okay, in the morning and see if the adrenals are going to respond to this shot or not. So if they are responding in abnormal way, there is a cutoff for the cortisol that we are going to measure. Okay, further, if it's very high, this is a diagnosis for congenital adrenal hyperplasia. And if the adrenals are not responding at all, or they are responding very mildly, very low cortisol levels, this is adrenal insufficiency. So of course here we are dealing with a case of hirsutism. So we are expecting to see high levels of cortisol after taking the shot. So if we get back to the question, and really I'm thanking you so much for making me realizing that we are having synactin test here. Synactin test is the correct answer, of course. ACTH, as I told you, if it's there, but there is no synactin test, okay, but it's not accurate. Okay, ACTH means I'm going to detect the levels of ACTH in her blood. Synactin test means I'm going to give her a shot of ACTH and see the result of this shot. So here we are. This is our algorithm. We have clinical features of hyperandrogenism, and we can have features of virilization. Okay, so if you are having any features of hyperandrogenism, you need to confirm it biochemically. Biochemically means doing free androgen index. If it's not there, you can at least do the testosterone and sex hormone binding globulin. This is what free androgen index means anyway. Okay, and I'm going to have a result. This result could be less than 5 nanomoles per liter, which is mostly going with PCO. It's more than 5, I'm dealing with something more severe from PCO, something that secretes a lot of testosterone. This could be adrenal or ovarian, I have no idea. Or I could be having signs of virilization. In that case, when I reach at this point and I need to know whether this is adrenal or ovarian, I'm going to order, of course, the ultrasound, at least to exclude masses, whether it's adrenal or ovarian. Biochemically, I'm going to run a simple test called 17-hydroxyprogesterone. Okay, this test, guys, can help us know if this is congenital adrenal hyperplasia or not. And if it's there within the options, by the way, it's going to be the correct answer. Okay, but they already excluded the tumors by the ultrasound. So now I want to confirm whether this is congenital adrenal hyperplasia or not. So in order, if I want to use something to help me out between tumors and congenital hyperplasia, you can run the 17-hydroxyprogesterone because usually it's going to be normal in tumors. Tumors are secreting testosterone only. But in congenital adrenal hyperplasia, I'm having a defect in the enzymes. If you remember the pathway and steroidogenesis from part 1. So anyway, I'm having one of the precursors of the cortisol going to be high, this one here. and it should be measured in the follicular phase. If it's borderline, okay, or you have no idea, you can confirm by the synactin test, which is called ACTH stimulation test. If it's high, this is a confirmation of non-classical or late onset congenital adrenal hyperplasia. Let me see your questions. Oh, yeah, sure. Look, simply, when you say ACTH, ACTH levels, it means what? It means you are looking for the concentration of ACTH. But when we say synactin test or ACTH stimulation test, this is the other name, stimulation test, or short synactin test, or all our names. It means that you are going to give a shot of ACTH hormone in the morning and then look for cortisol levels. You are looking for how the adrenals are going to interact with this ACTH you have given her. This is, by the way, one of the things that we can use for both congenital adrenal hyperplasia or adrenal insufficiency. Because if you find that the result is low cortisol, it means what? It means that I tried my best to wake up the adrenals, but they are not working. They are not responding. So this is adrenal insufficiency or adrenal failure. On the other hand, if you are having high levels of cortisol and they use a specific cutoff, okay, it means that you are having hyperplastic adrenal cells, which means they are overactive. They are secreting cortisol in high amounts. Okay, got it? Or still vague? Okay, all good? All good, alhamdulillah. Okay, I think if Dr. Rabah is with us, she's going to continue with you. Let me see if she's here. Yeah, she's here. Dr. Rabah, you are having the host now.
Hello, everyone. How are you? Thank you, Dr. Nada. Thank you for handing over. How are you, everyone? And Dr. Sarah is asking you, please, to complete the algorithm. So, starting another important topic from the gynecology EMQ for the MRCOG part 2. One of the topics that repeatedly appear in the exam is the fibroids. So you will have here in this EMQ scenario, for each description below, choose the single most appropriate answer from above list of options. In the scenario number 1, we have a 45-year-old and she is nulliparous, being evaluated for inflammatory bowel disorder as inpatient. Ultrasound show 5 cm fundal fibroid and 3 cm anterior wall fibroid. Her periods are regular, 4 to 5 days in 30 days, and she denies any intermenstrual bleeding. She is up to date with the smears with normal result. So what do you think I would do? This is a very beginning of fibroid management. If I have asymptomatic fibroid and it is discovered by chance months. What is the action? Expectant management or a conservative management, yes. So I will keep, you know, in mind that this patient is diagnosed, right, with the fibroids. However, no active management will be done. The patient could seek help at any time if she had heavy menstrual bleeding, intermenstrual bleeding, or pressure symptoms. And at this time, the doctors are going to help her, right, with according to what is the need for her. Okay, what is the predominant? So I would choose the conservative management as you all, my dear friends, have chosen. Is that okay? Everyone okay with L? Or do you have any other option? All good? Okay, good. Yes, it's L. Yeah, well done. Good. So let's move to the next. Next scenario here is about a 36-year-old, and she is nulliparous and being evaluated for secondary subfertility. Okay. She is having a regular heavy period lasting 7 days every month. Ultrasound shows a 4 cm pedunculated fibroid impinging into the uterine cavity. So if I have a fibroid and it's pedunculated, right, and it's in the uterine cavity, what you will, yes, you will just need to remove the fibroid using, it's a submucosal fibroid, of course. Yes, submucosal resection, yes, of the fibroid using a hysteroscopy is the best. So what answer match your opinion here? Yeah. Okay, so we have D. Yes, excellent. I is saying the transcervical resection of the endometrium. Which one is more specific, Dr. Yusra, my dear? Okay, thank you very much. Thank you very much, Dr. Yusra. And I would like to thank you very much for your lovely message as well. It touched my heart. Thank you very much, Dr. Yusra. I've just seen the message. I know that I am very late in replying to personal messages, but believe me, I reply to you in my head and in my heart as well. I'm so sorry that I didn't text you immediately when I saw the message. I love you too, my dear. Thank you. So here we have a 36 nulliparous woman is being evaluated for secondary subfertility. She had regular heavy period lasting for 7 days every month. Ultrasound show a 4 cm sized pedunculated fibroid. Yes, this one we have solved it. This is D. And we have here, yes, number 3, 34. Para 1 presented 4 weeks after her delivery with vomiting and abdominal pain. She's complaining of vaginal bleeding and started 3 days ago. Her hemoglobin level is 8.8. On examination, uterus is about 18 weeks of size. She is having a fresh vaginal bleeding. Ultrasound to show enlarged uterus without any retained product of conception. So what do you think? Vomiting, abdominal pain, bleeding, and low hemoglobin. Okay, we do have here options, okay, for the management. And remember, my dear, what is the leading sentence in this scenario? The leading sentence in this scenario is about appropriate management, okay? Most appropriate answer. That's what you will advise as a management plan. Let's say that you are telling you about this case, right? So what you will do. Antibiotics, are you sure? Are you sure antibiotic first for this patient? Again, read the scenario. 4 weeks after delivery, vomiting and abdominal pain. Vomiting and pain. Complaining of vaginal bleeding started 3 days ago. So, she had pain, bleeding, vomiting. Hemoglobin is 8.8. On examination, uterus is 18 size, and fresh vaginal bleeding is there. Ultrasound is done already. So my friends who suggested the ultrasound, it is done, okay? And it's enlarged uterus without any retained product of conception. So now, what do you think? If he give you fever, for example, okay, you would start with the also IV fluids and antibiotics, right? So now this patient, she's coming with pain, bleeding, low hemoglobin, vomiting. What I need to give? Appropriate from this option. She could have endometritis. She could have, okay, so which one to start with? Yes, the intravenous fluids and analgesic, right? So I'm going to start with her because she's bleeding and she's having pain, right? And she has vomiting, and vomiting could be serious in this case, right? In the postnatal, vomiting when it is excessive and associated with bleeding, that means this lady will be dehydrated and she will have electrolyte imbalance, right? So just to stabilize her, right? And then you will work up for the diagnosis, for the appropriate diagnosis and management. So what I have here available, okay, will be the intravenous among these options. The other option could be, of course, could be consider antibiotic, but I need to have a look again to the scenario and see if there is a clear indication for antibiotic like fever or increased inflammatory markers, yes or no, okay? It could be endometritis, of course, it could be, but I don't have any, clue at the moment to start on the antibiotic. So at least I will stabilize her, make her pain-free, and complete my investigation, right? And I will prescribe, the appropriate treatment afterwards. Would that be fine? E, vaginal hysterectomy? No, not E. Not E, Dr. Ala. You mean that D, submucosal resection? No. F is antibiotic. Ah, I'm sorry. Yeah, I'm so sorry, Dr. Ala. I'm sorry. I am not still in the mood. Yeah, you are asking about the key for the answers. I'm sorry. So the key for the answers for the first one, right? It was a hysteroscopic resection, yes. And the second one, this was this one, the pedunculated, this is hysteroscopic resection. First one is reassurance or conservative, right? So conservative, right? For the first one because asymptomatic. Then for the fibroid, this one, it will be the hysteroscopic resection. And this one who have no retained product of conception, you start with IV fluids and analgesic. Okay, and then let's see, question 4. A 43-year-old patient admitted into acute urinary retention. Okay. Fever and dysuria. She recollects. Okay, Dr. Asar, my dear, don't worry. I will repeat the answers again. Don't worry. 43 years old patient is admitted with acute urinary retention, fever and dysuria. She recollects having heavy period for the past few months. On examination, there is a central, okay, 20-week sized mass. So what you will do for this case? Retention, and the retention, of course, lead to infection. Infection will present with fever and dysuria. Then she had heavy period, history of heavy period, and on examination, there is a central 20-week sized mass. Yes, so I have a large fibroid here. Yes, that my first response will be for the castrations, right? But let's see, okay, what else could be the correct option in this case. Yes, all the options are here. Hysterectomy, of course, no. No, 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 no. Okay. This patient need antibiotic? Yes. I need to relieve the retention. Yes, excellent, excellent. Well done, everyone. I need to relieve the retention with the castration, and I need to give antibiotic because she is already having the UTI. Yes, and it seemed like it's a complicated UTI as well, with fever and dysuria, right? Yes, you will decide the management accordingly afterwards, my dear. Okay, so Dr. La, the management, the best management afterwards will be decided. Okay, but what is appropriate, most appropriate action now? Most appropriate is that you give the patient something for the fever and the dysuria and relieve, of course, the acute urinary retention first. That's why the castration. This is what you need to think about to save her kidneys at the moment, right? Good. So, for the question number 5, now I have a 40-year-old Afro-Caribbean, which is a risk factor for fibroid, present to her GP with dysmenorrhea and heavy period. Her hemoglobin is 9. Ultrasound of the pelvis show a 26-week size uterus with multiple fibroids. So what is the appropriate management? So when to choose myomectomy, Dr. Sarah, my dear? Myomectomy also always I would think about when there is need for fertility, right? Because a 40-year, she could have completed her family, right? I don't know, right? Maybe not interested. He didn't tell me anything about her family or fertility wishes, right? So I couldn't actually say that for specific, I will choose the myomectomy. This is no. Myomectomy should have a reason. Yes, this patient, as most of you have said, that she will need GnRH. It's a multiple fibroids, right? And it's 40 years. So multiple fibroid, very big uterus, right? So what could be the appropriate surgery for her? It will be the hysterectomy based on her age, right? I don't have a specific indication to do alternative management, right? Yes. So GnRH to be started and followed by hysterectomy, right? So again, my friends, please don't choose myomectomy, okay, in any option, in any case, without a clear indication from the examiner, right, that the patient wishes to preserve the uterus, especially if there is multiple fibroid and large uterus, large to the size of 26 weeks. Have you seen a lady with 26 week size, pregnant? Okay, so imagine this is her size of the uterus. So removing multiple fibroid from this big size uterus in 40 years old is not the appropriate management, right? Okay, okay, my dear. So this is, if no fertility wishes, I wouldn't advise to go for the myomectomy if there is in this case at all. Okay, and even by the way, with this big size, okay, the outcome is not going to be very nice to the patient or for us, and also it will be very, you know, very traumatic surgery, right, to the uterus and for the nearby structure. It doesn't say complete, it just gives you the age, doctoral. It's 40. Okay. So why would I suggest a special management? Okay. Yes. So the answer here, it will be O, GnRH, followed by hysterectomy. Okay. No, um, this is the answer. Okay. I have here in the chat box, Dr. Soha, my dear, you are suggesting total abdominal hysterectomy, which I agree with you that this is fine. Okay. Of course, advise the GnRH before to reduce the size and make the surgery more accessible. But bilateral salpingo-oophorectomy in this case, no. Why no, my dear? Whether the patient want to keep her fertility or not, okay, and which is not mentioned in this scenario, so I'm not worried about it. The patient is 40 years. In a patient who is 40 years, okay, how many years is still for the menopause? 10 to 12, right? So I am now causing, by removal of the ovary without an indication, right? I am causing this patient to have a surgical menopause. So no. Okay, dear? No, it's not indicated. We remove the ovary when there is an indication for removal. Like, for example, risk of cancer. Okay? So no removal here of the ovary. GnRN, okay. GnRH analog as a standalone, okay, management is not enough, right? We don't use the GnRH alone, but we use the GnRH, right? We use the GnRH analog, right, before the surgery, right? But it's not going to be a solo treatment for a fibroid, correct? Okay, I hope it's clear so far. Okay, let's revise answer. You are welcome. For my friends who attended late, a 45-year-old, and she is evaluated for another problem, which is inflammatory bowel, and she's inpatient, meaning that the patient is already, she's suffering from one problem, and she have asymptomatic fibroid discovered by scan. So just a conservative measure. Okay, so for one is conservative measure. Here for two, case number two, it's a pedunculated fibroid. Okay, so submucosal resection of the fibroid using hysteroscopy will be fine. Here for this patient, number three, now enlarged uterus without any retained product. The problem with the patient that she presented with vomiting, pain, and bleeding. So stabilize the patient and then search for the cause. Could be anything, right? It could be even a red degeneration of a small fibroid. I don't know, right? But I will stabilize her and then find out what is the problem, right? Here in the four, the patient have acute urinary retention, which is castration, fever, which is antibiotic. Okay, so I will search for the option that have castration and antibiotic. Okay, not not transresection of the endometrium of fibroid. Okay, my dear, submucosal resection of the fibroid, not for the endometrium. Okay, Dr. Sumaya. Here I have one option says submucosal resection of fibroid or the resection of endometrium. Which one you will choose for a fibroid? You will choose D, correct? So it's D, not I. Okay, clear? Okay, thank you very much, my friends. I hope it's all clear to you guys. Let's say, okay, in the EMQ, it's very difficult to predict actually which answer to choose, okay, in the EMQ in the exam straight away. So I can't give you like a formula for all the answers because again, every scenario makes a different. Every word in every scenario makes a different. Every group or collection of options makes a different. And the most important thing, the leading sentence in the scenario makes the big difference. Okay? So let's say I'll tell you, for example, okay, I can tell you for a patient who is asymptomatic and discovered a fibroid accidentally, conservative, right? I can say this, right? Why? Because this is most likely you will not find okay, other options for this patient. It's conservative, correct? When I say, for example, patient had fibroid and she wants to keep her uterus or she wants to have babies, I can tell you, for example, myomectomy. Is that 100% correct? No, it's not correct. I can't say it's a rule to follow. Why? Because this will depend on the size and location of the fibroid, right? Correct? Maybe the patient have a small intramural fibroid does not affect even the cavity, so no need to remove, okay? Right? This is one option. Another option that maybe this patient, she refused the surgery, then myomectomy is not suitable for her, right? Maybe the size and location of the fibroid is submucosal, that means hysteroscopic removal, right? So I can say that you find this patient with this answer is that. No, it will be every question is taking as individual, you know, uh, equation. I'll tell you to make it easy, guys, deal with the EMQ like the mathematics, right? So in the mathematics, you remember those days in school, you used to have anything, subtraction, division, anything, right? So you know the principle, but each question will be answered individually, correct? This is what we need to do. Now, friends, let's have a look here for another set of the EMQ questions. The single most appropriate answer is requested again, and this EMQ is about menorrhagia and heavy menstrual bleeding. So I have a patient who is 15-year-old, presented 6 months after menarche with continuous bleeding for 3 weeks on 2 occasions. She is not sexually active yet. So what you will do for this patient? Okay. Okay. So guys, continuous bleeding for 3 weeks. This is comes with what? Yes, if they ask you, of course, you can consider this. 3 weeks. This is an indication of what? Anovulatory, right? Yes, anovulatory. And this is looks like very lengthy period for a 15 years old to have heavy bleeding for 3 weeks. This will lead to anemia and it will lead also to social problem, right? In a teenager, attendance of school and everything, right? Okay. So do you think that tranexamic acid is enough for this patient? Okay. So I have here tranexamic acid and I have combined oral contraceptive pills. Which one you will choose? COC. Yes, COC will be much better in this case, right, to regulate her cycle, right? Since she's 15 and she had prolonged bleeding, right, for 3 weeks, right? This is very severe actually. So continuous bleeding, I need to stop that. And 3 weeks on 2 occasions, that's mean the patient had 2 period, each one is 3 weeks. Okay, she's not having every month, and this is means she need a regulation of her cycle. Correct, my friends? I'll tell you, my dear, if this patient in my clinic, I would perform an ultrasound, of course, right? Right, Dr. Ala? Believe me, if this is in my clinic, I will perform ultrasound. Why? Because, because, right? If it is my clinic, I am the one who takes the decision, right? But in the guideline, in the exam, you have to follow the guideline. Usually, this patient presented to the GP, right? This is a UK practice, my dear, right? So what this patient will do at the GP? I'm not going to see this patient as a gynecologist yet. She will be seen by her GP first, and then the GP, what the GP will do? The GP will assess the patient, right? No palpable mass by abdominal examination, so no need for ultrasound. Now they will start by the first line of management, right? And then they will see. The patient will have to follow up with her GP, right? And if there is any other concerns, she will be referred to me in the gynecology clinic. Correct? Yes, and no availability of ultrasound at the GB office. Actually, the GB to request the ultrasound, he has to write justification. Okay, so the ultrasound department will accept his referral or her referral. So no justification in this case yet, right? If there is abnormality in the on the examination, you remember the heavy menstrual bleeding guideline. If the uterus is palpable, right? Per abdomen or palpable masses or any concerns, you will perform a pelvic ultrasound. Otherwise, no indication in the guideline. Okay? So this is the main problem that I understand when most of my overseas friends are attending this exam, trying the questions of the heavy menstrual bleeding and menorrhagia. It makes like an error to them. Why not starting with ultrasound? This is the logical practice, right? And as I told you guys, I have practiced in Egypt and I have practiced in the Gulf before moving to the UK. So I know, okay, bedside ultrasound, it was the first thing we would do for every patient, okay? But no, not in the guideline, not in the UK. Answer here will be L, my dears. Dr. Khadija, who left the meeting. Okay, this is L. A 33-year-old para 2 lady present with cyclic heavy bleeding. So she had cycles and the cycles is heavy. She is not contemplating a pregnancy as she had recently broken up with her partner. So what you will do now, friends? Options. All options are seen. Okay. Yes, now the patient is sexually active. What is the first line management of a heavy menstrual bleeding according to the NICE guideline? Myrina. Myrina, why? 1 to tranexamic acid. She does not want to have a baby yet. So, guys, when we will go for the non-hormonal, I can do it as part of the symptomatic relief while I'm performing investigation, okay, or patient is awaiting treatment for fibroid, for example, like surgical treatment or so. But hormonal, remember, first line is Myrina. This patient, she recently broken up, okay, with the partner. She is not contemplating a pregnancy. So why did you give her a tranexamic acid? Give her Myrina and finish her problem, right? No, Myrina is not after investigation, Dr. Heba. It's not after investigation. GB can insert Myrina based on careful assessment and history and examination. Okay, right? So the Myrina will be after examination, not after investigations, right? And if the GP wanted to perform a test for this lady, what test will advised? What test will be advised? Here, full blood count. Not TVS, not TVS, not TVS, Dr. Yusra. Look, my friends, I'll give you. Okay, I will repeat with you. Okay. No, yes, full blood count. No TVS, no TVS before Myrina, wallahi. It's not TVS. It's examination. Look, my friends, the problem with the heavy menstrual bleeding and menorrhagia in the NICE guideline, again, please listen carefully to me. I'm saying this, okay, after 7 year experience with teaching of the MRCOG. Okay, so guys, NICE guideline speak about UK practice. What this is for UK professionals, right? And it's not, by the way, a special guideline for gynecologists, like the RCUG guidelines. The NICE guideline is a guideline for all the healthcare professional, including the GB, right? So some lines there, okay? Those lines there is special for the first contact of the patient at the GB clinic, the initial assessment. Okay? They have to start on some management, right? Symptomatic relief after careful assessment clinically before requesting in investigation like scan or hysteroscopy or so. When and how, right? To request the investigation, this is very important for your exam. So I have to give this introduction. So please bear with me. Now, my friends, this investigation for the cause of heavy menstrual bleeding. I have patient presented with a problem, right? Like which problem? Woman with suspected submucosal fibroid. So this is not only a heavy bleeding. This is not only amenorrhagia. This is a problem, right? What type of problem this again? Could be suspected submucosal fibroid, polyp, or endometrial pathology. Okay, doctor, how would I know? How would I know that this is have a submucosal fibroid, endometrial pathology, or a polyp? Yes, you will know as a clinician from the history, right? This is the beauty of the clinical assessment. From the history, this patient have symptoms suggestive of endometrial pathology. Okay, so I will manage this patient as a high risk of endometrial pathology, right? History. Yes, history. History of what? History of intermenstrual bleeding. So when the patient comes to you in the clinic, okay, and she's complaining of bleeding in between two periods, bleeding in between two periods, not only heavy bleeding, right, during the menses or her periods become heavier, then what you will do in this case? You will think endometrial. So if the patient comes to me and tell me, my doctor, my period are regular, but I have in between the periods, I have bleeding some days on and off, or even continuous for another 5 days or something like this. This is suggestive of that this patient have something in the endometrium. Clear, my friend? So for such patient, what is the first line investigation? For such patient, what is the first line investigation, my friends? Not TVS. Not TVS. We are speaking here about the NICE guideline. So this is to make it easy for you guys, okay? Avoid the TVS answer as a first line in this case, okay? No, it's outpatient hysteroscopy. Why outpatient hysteroscopy? Because the TVS can tell you the size of the uterus, can tell you if there is sickness, for example, in the endometrium, right? If there is masses like fibroid or something. But how you will test for the endometrial, okay, pathology by TVS? No, it's a hysteroscopy and biopsy. Okay, so hysteroscopy and biopsy. Anyway, I'm telling you everything with referral, right? So this patient should be referred to the pathway, right, of the outpatient hysteroscopy, right? And by the way, there is some risk factors that makes this patient even at risk of endometrial cancer. Like this patient is obese, like this patient, she have family history, like this patient, she had PCOS and diabetes. So I'm thinking that this is high risk of endometrial pathology and she presented with intermenstrual bleeding. I will go to the detection endometrial cancer pathway, remember? Okay, so this is for outpatient hysteroscopy. What if the patient declined the hysteroscopy? At least have a look by the pelvic ultrasound. Pelvic ultrasound and not the TVS. Okay? Yes, taking tamoxifen. Yes, exactly. Well done. Okay? So, in this case, the endometrial biopsy is going to tell you what exactly the problem in her endometrium. Why this patient have intermenstrual bleeding? So, how about this patient who have a possible large fibroid? Doctor, how will I suggest a possible large fibroid if I am in a GP and I'm sitting in the clinic with no ultrasound? How? Yes, I'll tell you how. Number one, from the symptoms, if the symptoms are suggestive of pressure symptoms or feeling of lump and mass in the tummy. So the patient have pressure symptoms like what? Pressure symptoms like urgency, urinary urgency, or repeated UTI. Correct? Correct, my friends? Okay, so this is one of the things. The patient also, she had incomplete emptying of the bladder, right? Because there is a mass that affect. Okay, this is one thing. Another thing, that while I'm examining, large fibroid will be palpable by examination or no? Yes, it will be palpable by examination. Okay, good. So that's mean I will perform a pelvic ultrasound. And why pelvic ultrasound, not TVS? I'll tell you, because it's large. I suspected that this patient have a large fibroid, correct? So do you think that the TVS will be helpful in the large size fibroid? Or pelvic ultrasound is more helpful? No, pelvic ultrasound is more helpful. And if you need after this to complement the pelvic ultrasound with TVS, it will be fine. But when I say large, suspected large fibroid, you tell me pelvic ultrasound, okay? That's good. Which patient in the NICE guideline need TVS? Surprise that the patient or the group of patients who need the TVS, those who are presented with suspected adenomyosis. Again, doctor, how would I suspect adenomyosis? Heavy menstrual bleeding and painful cycles. So she had pain, she had dysmenorrhea, and she had heavy bleeding, menorrhagia. So this patient now have both problems, the pain and the heavy period. And by examination, I may feel the enlarged, bulky uterus. Okay, so in this case, I will start by TVS. Sometimes in the cases, my candidates, I know from some of the book questions, you will be like a little bit confused. This pain with a cycle or monthly pain, and have bleeding as well, and you're thinking maybe this is endometriosis. Okay, good. If you think endometriosis, what will be the investigation of choice? What will be the investigation of the choice? The TVS. So finished, right? Right? So patient have lower abdominal pain or have a pelvic pain. She had dysmenorrhea, right? So she had heavy bleeding. I'll tell you that endometriosis not necessarily comes with heavy bleeding, but anyway, adenomyosis, okay, is there TVS, endometriosis TVS, right? Correct, my friends? So this is how you choose the appropriate investigation in the heavy menstrual bleeding. So let's say the patient have nothing, literally nothing, just heavy bleeding. She comes with menorrhagia. The patient tell you, doctor, I have my cycle, okay, 5 days, and it become very heavy. I have to change pads, I wear tampons, or otherwise, it's very difficult. Okay, I found that it even leak, or the pads are soaked so quickly, and so on. Okay, so if the patient have just the heavy period, okay, what can I give her? That will depend. Depend on what? Depend on the patient wishes. Patient want hormonal or non-hormonal. Patient planning to be pregnant, that she had heavy period. She's planning to be pregnant. So give her tranexamic acid. Give her mefenamic acid if she had pain with the period. Right? Because she's planning to be pregnant. Correct? Otherwise, no plans for pregnancy. Right? Give her CUC, maybe. Why not? Give her progesterone if the CUC is not suitable. Right? Okay. Give her Mirena. Yes, Mirena. Why not Mirena? Yes, I'll tell you why Mirena. Because, my friends, Mirena had other benefits. Like what? Number one, if the case had Mirena, okay, the total cost of Mirena compared to monthly COC. Mirena can stay 5 years or longer, right? Even longer in some cases when they are old, if you remember this update. So let's say 5 years. 5 years and COC, which one is more costly? If you are a government, okay, and thinking like just, from the point of the funding and money and all, okay? So Mirena is less costly in 5 years compared to COC, right? This is one thing, right? Okay. The patient who had Mirena, how many times she need to visit the doctor to repeat the prescription, or go to the even pharmacy to repeat the prescription? Once in 5 years. She will go once in 5 years to her GP, one appointment. Okay, right? The patient who have TOC, how many times she need to come back to her GP, even if the GP give her 3 packs every time to keep like 3 months supply? She will need to go even every 3 months. She will need to have an appointment. If she's working, she will take time off, right? Because the GB only working from 8 to 5, and everyone else also working from 8 to 5. So means that she had to ask for a time off from her work, right? to go to the GP. Having a GP appointment also, it's not very easy, right? And if any one of you lived in the UK, they will relate, of course. And she will go to the pharmacy. Also in the pharmacy, there is a queue in the pharmacy, right? And she had to pay. So why all of this hassle? Put the Mirena, and Mirena has other benefits. Like what? If you compare risk of COC to risk of Mirena, which one, okay, is higher risk of DVT or problems in general? COC have higher risk, right? Okay, which one can be protective to the endometrium? And even if the patient have a small fibroid, this is actually will prevent this fibroid from enlargement and all. Mirena had benefit. Good. Okay, well done. Okay, so far I'm not finished yet. Okay, how about COC failure due to user mistakes, incorrect use of the COC, unwanted pregnancy, right? Right? Okay, so now I have also in the lifestyle, patient who have myelina, she might have light periods and she develop just amenorrhea after the myelina, right? While patient who have CUC, she will need to have a withdrawal bleeding, correct? And yet this is again another bleeding. So which one is more comfortable from the lifestyle point of view? I can ask all the ladies here, what do you think? Having myelina or having CUC, having monthly bleeding or light bleeding or no bleeding? They will, most of the ladies, especially if the lady suffering from heavy menstrual bleeding or even intramenstrual bleeding, she will prefer the myelina, right? Okay, so now if I compare this medication to this loop, right? If I compare this method to this method, which one have the priority here to choose as a first line? It's the Mirena, right? So the GP can prescribe the Mirena, right? And say bye-bye to the lady, not seeing her in the next 5 years. Thank you very much. Bye-bye. Correct? Not coming with bleeding again, not coming for prescription, not coming for emergency contraception, not coming for requested termination of pregnancy because failed the tablets, right? So this is how they think, simply. Really, this is how they think, right? So that's why the Mirena is the first line of treatment. I hope this long story that I told you, okay, is not a waste of time, and you will remember in the exam that Mirena is preferred as first line treatment in the UK, right? Okay, that's good. What about the girl? The girl, 15 years old, who's not started her sexual activity yet. Yes, this is one reason where I will not insert the Marian. She's still virgin, right? So that's why I choose COC in this case, right? Yes, I didn't choose a Myrina because she's virgin, nothing else, right? Good. And here, my friends, if the patient want a Myrina or the patient is convinced with a Myrina, do I need to run investigations before the Myrina in terms of scan or anything? No. No, you don't need. Just examination. Okay? So examination and insert the Myrina. So this is the GP practice, right? And it's not, by the way, she's not going to come to the gynecology clinic to insert a Myrina. Okay? Risk of DVT is small because the risk of VTE start from 35 years with the start to be significant from starting from 35 years in the COC. That's why we don't advise the COC after this age unless we have a reason, an indication, benefit outweighs the risk. Right? And of course, the risk start increased with the obesity and so on. Okay, friends, clear so far? When to choose mefenamic acid? When to choose mefenamic acid if the patient comes to you, okay, and she says that she is young, all her problem that she is having dysmenorrhea. Give her mefenamic acid, okay? So that's easy. A little bit heavy cycle with dysmenorrhea, mefenamic acid can help. That's it, right? Not affecting the quality of life or not, affecting also the hemoglobin. Like she's not having hemoglobin 8 because of the bleeding, and you give her mefenamic acid. No, just for simple complaint, right? And mefenamic acid comes with the pain, and also it can be used while the patient is awaiting for another definitive management. Let's say a patient have fibroid, right? And she's awaiting for myomectomy. So she can benefit from the some symptomatic treatment while she's awaiting for the investigation or awaiting for the hysteroscopy to be done if you think that she is a high risk. Okay. COC if she's unmarried, my dear. No, not unmarried, virgin, not unmarried. We will say not starting sexual activity. Remember that we are solving problems from the UK, not from our societies or our background. Okay. When the patient tranexamic acid is a very good option for the heavy menstrual bleeding, right? In a patient who wants to she's trying to get pregnant, okay? So this will be very helpful to her to reduce the amount of the bleeding. I can't choose Myrina if she is like, for example, looking for fertility option or she's awaiting to get pregnant and so on, okay? And also this will depend on the problem that this patient have. So of course, I will not start the tranexamic acid in a patient who have multiple fibroids. This is not enough for her, right? But in a simple complaint, when the patient presented it to the GP, she can have the tranexamic acid or mefenamic acid according to her complaint. But heavy menstrual bleeding that affected the quality of life, think of Myrina first. If Myrina not suitable, like virgin, for example, or the patient doesn't want, then you go to the COC. If the COC not suitable, go for the progesterone tablets. Is it clear? Yes, mefenamic acid can help with the pain more than tranexamic acid. Tranexamic acid help with the bleeding. Mefenamic acid help with the pain. Okay. Okay. So now, friends, 15 years old, present 6 months after her menarche with continuous bleeding 3 months is what you will 3 weeks, sorry, in 2 occasions. That's mean it's like she's having times of anovulation and then she had prolonged bleeding for 3 weeks. And this patient is not sexually active. What you will prescribe to her or not sexually active? Is it Myrina? No. Now I will go to the other one, which is the COC. Yes, you got the point why now COC is the logical answer for this case? Good. Another one is 33 years old, para 2 lady present with cyclic heavy bleeding. And she is not contemplating a pregnancy. So she doesn't want to get pregnant, okay? And she had heavy bleeding. And she is recently broken up with a partner. So now what we will do, yes, I know, Dr. Wajah, that we did this. First line of management now will be Myrina. Can I choose TVS for this case now? I hope not after we explain the heavy menstrual bleeding. No, right? She doesn't have an indication for the TVS and simply she is suffering from heavy bleeding every month and she's not getting to be pregnant. No other risk factors. So go for Myrina and that's it. and the myelina can be managed at the GB clinic. She doesn't need to come to the hospital for myelina. Now, a 47 years old. So in these cases, look to the age, right? And parity if it is present. So 47 with irregular, heavy bleeding. Okay? Irregular, heavy bleeding. Is it a risk factor? Is it a problem? Do you think so? Irregular and heavy. Yes. Irregular heavy bleeding is a risk factor, especially if the patient is 47. Okay. She is para 2 and she had been sterilized already. She continues to bleed and cyclic progesterone prescribed by her GB. So what is the management now? I have different, story here. Yes, exactly. So this patient did not respond to the simple progesterone, to the cyclic progesterone. Okay. And she is 47. So I need endometrial sampling, right? And she had irregular heavy bleeding. And this is one of the indication of hysteroscopy and endometrial pathology, right? Presence of risk factor and failure to treatment or response to the progesterone. Is it all clear now, my friends? For this patient? Yes, good. A 47, sorry, 26 now, not the 47. I'm repeating the same case. I'm sorry. Okay. In the 26, the question number 4, in this EMQ, old lady present with intermenstrual bleeding. She's 26, intermenstrual bleeding during the second week after her cycle. She is investigated for the same problem in the previous year. She had no postcoital bleeding and she's trying to get pregnant. For the investigation of the intermenstrual bleeding, right, I need to take a sample, right? Correct? So how would I do this? Yes, using the hysteroscopy. Yes. Okay, good. So now a 44-year-old Afro-Caribbean nulliparous lady present with 2-year history of dysmenorrhea and menorrhagia. Large central lower abdominal mass. She had been confirmed 20-week size fibroid. Ultrasound show multiple fibroid. And her recent hemoglobin was 84 milligram per DL. So what do you think now? What do you think about this case? Very similar to the previous one. The previous EMQ for the fibroid. Okay, so what do you think what could be the option of this patient? Okay, what is her age? Before you think of she's nulliparous, what is her age? 44. Is that the time where this patient is looking for pregnancy? Did he say that this patient wanted to keep fertility? No. So, enlarged uterus with multiple fibroid and anemia, what you will advise? Unfortunately, I don't have here the option of surgery plus the GnRH like the previous question. We said we can't choose the GnRH alone, especially that the answer is here, requested the single most appropriate. He didn't even say the next. Hysterectomy, sorry, yes. Okay, what is the difference between H and M? Yes, I agree. M more specific. Yes. Okay, yes, it's M. M is more specific. Yes. Yes, M is more specific. That's it. Okay. So yes, it's total abdominal hysterectomy. Yes. Tricky, not tricky. Believe me, it's not. Okay. These questions are typical exam questions. They are typical exam questions. I'm not choosing easy exam questions. I'm choosing EMQs that come in the exam and sometimes makes people feel like, oh my God, what is the choice? How to choose? How to differentiate between this option and this option? Okay, and this is what's my job actually. This is why I'm here. Why total? Okay. 1 second. Which one is again subtotal fibroid in the fibroid management in large fibroid? Subtotal hysterectomy or total hysterectomy? What do you think? Oh, okay. So 1 second, my friends. What if the value of keeping the cervix to the patient? No value. So what is the benefit of total hysterectomy and removing the cervix? Now this patient, right, will not attend the cervical screening program again. Why? Because now no risk of cervical cancer. So I have eliminated the risk of cervical cancer. This is one thing. Another thing, that this patient also, right, If she had any remnant of, let's say, I'm having a surgery for pre-malignant lesion, right? So any remaining of the endometrium in the cervix could turn into another problem in the future, right? So why keeping the cervix now? No, no need for cervix. Actually, my friends, again, I'm telling you, right, principles from the UK practice, the standard practice. Whenever you are planning for hysterectomy, better to be total than subtotal. When to choose to have subtotal hysterectomy? Only if there is difficulty during surgery. Like, for example, sometimes patient have previous surgery, she had adhesions, okay, and you are sure 100% that this patient is not having a problem in the cervix at the moment, right? Or the problem is not a cancer, it's for benign reason, okay? So this is the only indication of subtotal, right? Hysterectomy, okay? Otherwise, we go for total. When to go for oophorectomy? Oophorectomy is not a routine at all. Oophorectomy is done with a reason, okay? Like, for example, a patient have cancer, okay? So think, of course, of the oophorectomy because the risk of the cancer spread. Patient have high risk of cancer, or patient have endometrial hyperplasia, for example, with atipia, where there is associated 5% risk of cancer. So remove it, why not? And even in this case, we will say plus or minus, but this will be after patient counseling. Patient near to the time of menopause, and she has risk of ovarian cancer, go for the oophorectomy. Otherwise, no need. Patient have risk of ovarian cancer, remove, of course, no matter what. So guys, you got the point? So we always have a reason for the surgery. We don't remove organs from the human body without a reason. If there is a justifiable reason, then it will be fine. Yes, especially that this organ is not any organ. This is the ovary. So the patient will have a problem, long-term risk of menopausal problem, osteoporosis, cardiovascular problem, even cognitive problems. So we will need a replacement therapy. Replacement therapy might have problems itself and side effects. So why you will go for all of this? Okay, you must have a good reason for the oophorectomy to do it. And whenever you do oophorectomy, you do a salpingectomy with it. Okay. Again, because if the woman is at risk of ovarian cancer and you remove the ovary for this reason, you remove the tubes as well because there is a chance, right, of a primary tumor arising from the tubes. So remove it as well. Okay. So at this question, my friend, this is going to be, inshallah, another easy EMQ. Okay. So today you are going to reflect on the topics that we have revised: heavy menstrual bleeding, right? In the EMQ, fibroids. Dr. Nada, I think also she had the hyperandrogenism, or yes, the hirsutism with you. Yes. Okay. So this one topic, inshallah, will be more easy. For each part description below, choose the single most appropriate again. 26-year-old attended the gynecology clinic with a single painless ulcer on the vulva. Single painless ulcer. Does this remind you of anything? She is also 26. No associated itching. And on examination, there is a shallow ulcer on the labia majora with enlarged but painless lymph nodes. Yeah, it is. Okay, good, good, good. Okay, next question, my friends. Even before we go to the options, right? Everyone agree for syphilis? Yes, everyone agree with the syphilis. It's a primary syphilis, of course. Yes, good. So going to the next one. 37-year-old lady attended clinic with painless vulval ulcer of 4-day duration. She noted a papule initially, which later developed into ulcer. Just returned from the Caribbean holiday. Bilateral inguinal lymphadenopathy is noted. So this is differential diagnosis of ulcers. What ulcer will be there? Started as papule and then ulcerated. Chancroid. Yes, Dr. Arwa, this is a chancroid. And the chancroid, my friends, is done by what? Which bacteria is responsible for the chancroid? And this EMQ is very good example to show you differences between the chancre and the chancroid, right? So you can remember it. Yes, it's the Haemophilus dicrei. Yes, exactly. Well done. So next question number 3. Okay, so what do you think else, my friend? It's classically chancroid is painful, right? Classically, it's painful, of course. It will be like a painful genital ulcer, of course. But if there is an option that the chancroid can be painless, no option? Why you are so sure that there is no option? Yes, okay. Then could be. 1 second, my friends. To be honest, when I read this question, I thought that, like I'm solving quickly, quickly. This is a painful vulval ulcer and it become, yes, 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 yes. Like a pupus, right? 1 second. Okay. Check options, yes. You know, my friends, I'll tell you something, okay? I think that this is painful. It should be painful. It should not be painless. I'm sorry, okay? So here, I'm sorry, guys, okay? Because I'm revising everything now, okay? In the lymph granuloma venereum, my friends, the lymph nodes are typically painful or no? Yes, okay? So I would tell you, okay, this should be a painful ulcer. This should be a painful ulcer. I'm sorry. Honestly, I was reading this fast, okay, as I was texting somebody on the phone. So I'm sorry. I'm so sorry for this. I just read this fast, okay, and I was thinking that this is a painful. That's why I'm telling you, oh, I this is difference between the chancre and the chancroid. No, it should be painful. I'm sorry. Okay, so this is a typing error. It should be painful ulcer. Yes, it's they are text me from my kid's school. Okay, that's why I was distracted a little bit. So I'm sorry. Here, it's a bad habit. Don't do this. Okay, if you are conducting a class or you are concentrating with a patient or solving questions, don't answer text. So here, 28-year-old is admitted to the surgical ward for acute urinary retention. She's already on oral antibiotics. 2 days later, she developed severe pain in the vulva. On examination, multiple painful shallow ulcers were noted on the labia majora. It should be painful. It should be painful. The lymph granuloma is painful, and the tender also lymph nodes. Thank you for my friends, guys, that you saved this question. Okay. Okay, so here we are speaking about what? Acute urinary retention. That's easy, right? So herpes, right? 34-year-old attended the gynecology clinic with dyspareunia of few months duration. She had recently noted pain during insertion of tampon. On examination, there is area of focal tenderness and erythema around the vestibule, not associated with lymphadenopathy, and the initial swab taken by the GP negative. So what do you think this focal tenderness and erythema? She is 34. And it caused dyspareunia. Let's see options. Let's see options. Okay. So which option you will go for? Okay. So now I have answers, okay, between A and J. Okay. So which one, guys, you think can make more sense in this scenario? Yes. So A can be more sensible in this scenario, right? This patient, she just have a vestibulitis, right? Yes, not mentioned that there is an oral ulcer as well, right? It's not mentioned. Yes, nowadays, my friend, this is what we called the vulval vestibulodyne, okay? And the old name that we used to say or call for this case is just the vulval vestibulitis. Because itis, that's mean it's inflammatory, right? When we say that this is pain without actually being able to determine what is the cause of this inflammation, okay? So it will be nowadays vestibulodynia, okay? Why initial swab? Because whenever you have a patient that comes to you with pain, like dyspareunia, and she had focal tenderness and erythema, you will take swabs, right? You want to rule out the infection. Answer is A, Dr. Yasser. Answer is A in this scenario. Is vulval vestibulitis. Okay, this is the one that I was just saying that it's now called a vestibulodynia because it's associated with dysmenorrhea in this case. You're welcome. You are welcome, of course. Okay. Please quickly. Okay. Thank you very much, everyone. Thank you very much, my friends. I appreciate your words. It means a lot to me, actually. Thank you. Okay, so we do have another EMQ here for the adnexial masses. Dr. Muhammad, my dear, I can send the answers at the end, okay? I will send it to the group, to the WhatsApp group. Thank you very much. Because I have also many things to do, so we want to finish fast and quickly. So I can send you as well, my dears, after we finish, okay? Some tips for the EMQs that we have solved today. So Dr. Amira, remind me, please, if I didn't send immediately after, remind me to send you a differential diagnosis for the vulval ulcers, okay? Single most appropriate answer will be required. An 18 years old presented with urinary frequency. On examination, she is found to have lower abdominal mass. Ultrasound shows 7 cm left-sided ovarian mass with mixed echogenicity. CT confirmed the finding with fatty content of the cyst, but no other pathology is seen. The CA125 carcinoembryonic antigen level are normal. What is the appropriate management option? So she's young, right? 18 only. And she present with urinary frequency. And she had lower abdominal mass. This mass had mixed echogenicity, right? What should be the appropriate action in this case? Okay, would you like to go for a laparotomy or a laparoscopy at 7 cm? You tell me, my friends, which one is best? Yes. We can go for the laparoscopy. Yes, we can go for the laparoscopy and bear the guideline. They are advising now that you go for the laparoscopy unless, okay, this is not suitable or a big size. The guidelines, did not tell us exactly what is a big size or a cutoff when to turn from a laparoscopy to a laparotomy, but they give us some advices regarding the approach, right, of this case. The approach will be by that you will go by using a retrieval bag, right? Avoid spillage of the cyst content, right? And you can take it out through the umbilical cord. So what if the size, okay, is still not possible to take it out, right? It will be by having a mini incision, which we call a mini laparotomy, okay? But we are not going to open this patient a midline laparotomy to take out this cystectomy or even a transverse, okay? So you will do a cystectomy, prefer to be the laparoscopic cystectomy with use of retrieval bag and avoid the spillage of the cyst content, right? And then if it's difficult to remove, you can use the mini laparotomy, okay? Yes, most of the advices that if the size less than 10, okay, this is from our practice, that if the size less than 10, it can be done by the laparoscopy. More than 10, you will go by the laparotomy, right? But I am just saying, okay, in the guideline did not specify, okay, the size where you will go for the laparotomy instead of the laparoscopy, okay? But this is from our practice. Most likely we will use the 10, okay, cutoff. In the next question, this is another case, but the age is different. So here, focus with the age, please. Perimenopausal with pelvic scan, right? For menorrhagia and was found to have 4 cm anechoic, thin-walled cyst, okay? And the CA 125 is 18 in this case. So 4 cm and 18. What is the appropriate management option? And by the way, this cyst, by the way, is found on incidental finding. So what you will do? All options are here. So you guys choose which one is more appropriate for this case. Nothing, right? There was nothing. Yes. Okay. Do nothing. Look, guys, perimenopausal ovarian cyst, when it is simple cyst and less than 5 cm, what you will do? Do nothing, right? Okay, so I have here options of do nothing, straightforward, okay? And I have more specific option to say discharge from the follow-up. She is not on a follow-up even. Guys, look to the scenario. Read the scenario carefully, okay? Read the scenario carefully. She is not even on a follow-up. The lady discovered this by chance, right? Pelvic scan for menorrhagia, and it was 4 cm anechoic thin walled cyst. Did not start a follow-up yet. Okay? Yes, so do nothing, nothing. No, not even, right? Not even discharge from a follow-up because there is no follow-up. You know when to say discharge from the follow-up, like a patient who had, for example, a follow-up and the follow-up show that there is no change or reduce in size. So in this case, it will be discharge from the follow-up. But for now, do nothing. That's it. Okay. For the menorrhagia, this is something else, my dear, right? So here he's asking you about the CA125, but for the menorrhagia, he didn't say anything. And also the options, it does not have here options for the menorrhagia management. It's all for the for the cyst management. All premenopause lists don't hinge in the guideline. I want to share that even postmenopause. Thank you very much, Dr. Athar. Yes, the new one, it says that if postmenopausal from 1 cm to 3 cm, there's nothing to be done for them. We will also have to reassure, and that's it. Thank you very much. A 54-year-old postmenopausal woman present with asymptomatic 4 cm. Okay, so now she's postmenopausal, but the size 4 cm and persistent for 1 year, right? CA125 is normal, an appropriate management option. So see here, this patient was in number 3, 54, postmenopausal. Okay, Dr. Najla? Postmenopausal, 4 cm, not changed for 1 year, and CA125 is normal. What you will do? So after 1 year of follow-up, what you can do? Either discharge from the follow-up or consider intervention after discussion with the patient, right? No, Dr. Asar, she doesn't need follow-up ultrasound after 1 year. Okay, this is already 1 year, so no need. So this patient now, what you will do? Either you discharge according to the guideline, right? Or what you will do? Or you will consider intervention, right? But he told you that 4 cm not changed and CA125 is normal. Yes, this is, yes, of course, it's either discharge or intervention. I just want to remind you with this algorithm, which I will keep saying, please, please, please have a look to this algorithm, okay? And revise it. It will be very helpful to you. This is the part when the patient have a cyst that is simple, right? I'm opening just the new one, but now our case is 4 cm, so it apply here, low risk case. And on conservative management, what I will do on the conservative management should repeat assessment in 4 to 6 months by repeating CA125 and the scan, right? If persistent unchanged, again, I will repeat assessment in 4 to 6 months. But if still nothing is done, individualize the treatment after discussion with the woman, either to discharge or to consider intervention, right? Is that okay? Right, alhamdulillah. So now this patient will be discharged from the follow-up, correct? So now here, this is the best use of the option of discharge from the follow-up, right? Where is the discharge from follow-up? This is I. Okay, so this is discharge from the follow-up, right? So guys, you got the difference, my friends who were confused between do nothing or discharge from the follow-up. You can see now the difference. I am so happy, my dear friend, that you got it now. Now, in the question number 4, a 32-year-old anxious lady present with lower abdominal pain. Okay? And she had past history of irritable bowel syndrome. Pelvic ultrasound show 4 cm. Ovarian cyst. Followed up 6 months later. I don't know why, but it was followed up. The cyst reported to be 5 cm. So now the cyst on the 5 cm size. Serum CA-125 normal, which is actually not indicated in this patient alone. She's simple cyst, right? This is simple cyst, so why? Anyway, so what is appropriate management option? Yeah, this is now become a 5 cm in size. Once it's a 5 cm in size, I need to follow up by scan only after 1 year, right? Yes, it will be by scan only by 1 year. Okay, yes, she had history. They are telling you history of irritable bowel syndrome, right? The simple ovarian cyst and the premenopausal usually it doesn't cause any pain unless it have some accidental, like what? Like hemorrhage, like torsion, right? So cyst rupture or hemorrhage within the cyst or torsion, this can be associated with pain. Otherwise, if just simple cyst, nothing. 4 to 6, no, 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 no. Now, my friends, even if there is no option, no problem. Okay? All the guideline, but now we know what is our guideline. If there is a simple cyst, right, in the premenopause, let me get you the premenopause, postmenopause. Once again, my friends, opening the file to help you. Okay, fixes the concept, okay? So if we have, anyway, till we find the file, inshallah, okay? If we have a premenopausal, less likely to have cancer risk, right? Cyst in the premenopausal complex will need to be managed, right? But if it is simple, less than 5, so nothing, right? Premenopause. Yes, ovarian mass. Okay, I think that even Dr. Nada, she had prepared the flashcard to you, mashallah alayha. So I will show you the flashcard of it. That pain, it could be the reason of pain. This is the significance of it, Dr. Mohammed. Okay. No, this is could explain the pain. Okay. Here, my friends, right? This is for the suspected ovarian mass or cyst, even in the premenopausal woman, okay? Simple, nowadays, this is from the GTG, okay? If it is simple mass and less than 5, nothing. okay? And we don't even need to do the CA 125. But if it is 5 to 7 here in this part, I'm reading this part, simple ovarian cyst, 5 to 7 cm in diameter, it should be yearly ultrasound follow-up, okay? If less than 5 in the premenopause, simple ovarian cyst, nothing. Generally don't require a follow-up because usually it will resolve within 3 menstrual cycles. But if there is ovarian cyst, simple but persistent, or it increase every time on the follow-up, like it was 5, then 6, then 7, and so on, this will be unlikely to be functional, and may warrant surgical management. Large simple cyst more than 7 will require MRI or surgical intervention. Okay? So simple cyst or mass less than 7 cm, okay, and present with pain, acute management, then go for laparoscopy. Okay? Clear, my friends? Okay. So now I have this, again, this case, premenopausal, and she had cyst 5 cm, and I don't care about the management that they have done before. I care about where is the point now of finding. Point of finding now situation is 5 cm, serum CA 125, normal on both occasion. So appropriate management will be annual follow-up, okay, or yearly ultrasound. All good? Okay. Number one again. No problem from number one again, my dear. I can explain. In number one, the case is 18 years old and she had urinary frequency and on examination found to have lower abdominal mass, and the ultrasound shows 7 cm, right, with mixed echogenicity. And the CT confirmed the finding, right, and no pathology is seen. So what is appropriate management for any complex cyst in the what we will do? Actually, we should do a tumor markers. If all the tumor markers are good, then we will advise surgery. The surgery would be, in this case, because she is young, okay, by a laparoscopy cystectomy, right? That's it. Happy so far? Okay, so one post-operative. One post-operative EMQ and we finish. Yes, dermoid. Still we can. Okay. Okay. Okay, one post-operative complication, EMQ, and then we will go, right? Yes. So, my friends, this EMQ to discuss the post-operative complication. Post-operative complication in the diagnosis, right, is not going to be very tricky. But the thing is that it needs a little bit of the clinical sense, right? So let's see the questions that we can have in the exam, because you always have EMQ to ask you complication in the exam, right? Or emergencies. So let's try this one and see. Dr. Amin, no. If she is premenopause, we will go premenopause. If she is postmenopause, we will go postmenopause, ovarian cyst. Okay, dear? Okay. In the older, yes, perimenopause, it doesn't matter. 47, I am 47. So what does this mean I am a postmenopausal now? Yeah, are you going to treat me as a postmenopause? No, I'm not. No, I insist no. Okay, I'm still young. So now, my friend, let's see. For each of the description below, choose a single most appropriate answer from the above list of option. Each option may be used once, more than once, and not at all. This one is 38-year-old, and she had a difficult abdominal hysterectomy for severe endometriosis on the third post-operative day. Still thinking of the postmenopause. This is a scary word. Oh my God. She felt unwell and developed a piking fever over the 38.2 on 2 occasions. Intravenous ceftriaxone, cefuroxime, and metronidazole. On examination, she is dehydrated, peripherally shut down and shocked. There is generalized abdominal tenderness with guarding and rigidity. CT scan show rectal contrast, show multiple fluid levels. So what do you think this patient is? Okay, so what is the appropriate management among these options? Yes, yes, I agree. So what is the best option of management here? He's not asking diagnosis, he's asking management. Okay, so the re-exploration of the abdomen, right? Or L, that this says nasogastric tube, intravenous fluid, and the correction of the electrolytes. What do you think, my friends, is more appropriate in the management in this case? Yes, so your diagnosis is correct that this is a bowel injury, right? So the diagnosis of bowel injury, I can't manage it conservatively. So here, this is a conservative nasogastric tube. This is no. If I have ileus, for example, okay, I would go for conservative. But this is a bowel injury, patient is shocked, I need to go for laparotomy, right? So I'm just watching your answers, my friend, and B is the correct answer. Okay? Not L, it's B. Yes, I need to go laparotomy. 36, laparoscopy for persistent left-sided ovarian cyst. She had later converted to an open procedure. On third post-operative day, she complained of left-sided chest pain and fever. The pain and fever. Chest examination and abdominal examination, normal. Chest X-ray show patchy haziness over the right lobe. Oxygen saturation, 98. And the ECG is normal. Okay, so if there is on the X-ray, if there is on the X-ray the patchy haziness over the right lower lobe, what's your diagnosis of this description of the X-ray? This is pneumonia. Yes, exactly. It's a pneumonia. So what you will do with the pneumonia? Antibiotics, right? Antibiotics. Yes, good. Yes, well done. Intravenous antibiotic. Another case of the complication. Case number 3, a 40-year-old total abdominal hysterectomy for a benign serous cystadenoma on the third post-operative day. She felt unwell with profuse vomiting. On examination, there is tense abdominal distension. Initial blood test results are normal, and abdominal X-ray show multiple fluid level. She felt unwell, right? And there is tense distension, but the blood test is normal. So what's your diagnosis? Before we go to management, what's your diagnosis? This is ileus. Yes, paralytic ileus, of course. So what is the management now? Now, this is the time to choose L, right? This is the time to say nasogastric tube, intravenous fluid, and correction of electrolytes. Happy? Yes. Okay. Last one is 58. Chronic smoker underwent total abdominal hysterectomy with bilateral oophorectomy for a persistent ovarian cyst, and intraoperatively they would develop the myocardial infarction and needed to be ventilated. She was in the intensive care and was later transferred to the high dependency unit post-operative. The 10-day post-operative was noted to have serious discharge from the wound, which should send to culture and has been antibiotics for a week. She's afebrile and initial blood results were normal. After 2 days, she's noted to have complete wound adhesions. So now what you will do for the complete wound adhesions? Can you treat with antibiotic alone? Can I treat wound adhesions with antibiotic alone? Complete? So, friends, what they say here, she was on antibiotic for a week, right? Initial blood risk was normal. What I will do now? Complete. Shall I go back for resuturing? What do you think? Why not? What is the patient problem at the moment? Guys, repeat again. Okay, read again. This patient, she started to be on a ventilator. Then she was fine, right? She went to the high dependency unit. And on the 10 days, so she had 10 days, her complaint is what? Was what? Discharge. This culture is done, right? And she had antibiotic based on the culture for 1 week. But what happened afterwards? Complete wound adhesions. So what you are going to do? So not taking a swab. I need you guys to just concentrate. Okay? I know my concentration today is not the best, but I need you please to concentrate. Yes. So I'm not going to repeat a culture or a swab again because already culture is done and the antibiotic received for 1 week, right? And now investigations are normal. So what to do? I will go for resuturing, right? Does this make any sense to you guys? So initially, she will need to have, this is burst abdomen, complete wound adhesions. This is the other name, is called burst abdomen, right? So this patient initially will need, you will assess her, of course, right? Initially, we give antibiotic for like some time, right? But she received the antibiotic for 1 week. Then I have to go to the definitive. The definitive, when the wound is totally, completely dehiscent, right, will be, right, surgical re-exploration of the wound, right? You will examine the wound, you will listen, assess the fascia, right? And you will exclude other parts of injury or necrosis inside, what led to this, problem. And you will check for infection or abscess as well. This is what we do in the surgical exploration, right? And then you will go for the wound itself, wound management. In the wound management, you will have debridement if needed. If you need to do debridement, you will do. And then you will do a mass closure of the underlying layers, right? And then you can do like some retention suture as well, okay? The negative pressure wound therapy is very good, right? Especially if there is high risk of infection, right? Negative pressure is very good, but I can't just put the dressing, okay, or the negative pressure wound therapy now alone. This is complete dehiscence. This is burst abdomen, right? So now it's the time for going for a definitive, right? Yes, resuturing. Yes, I have questions here or comments on the chat box. Dr. Wajiha, she is asking complete dehiscence means the rectus sheath also. It can be, yes, because they said complete, right? Correct? In this case, it will be mass closure for the sheath. Okay, so just have a look to the wound carefully. Rule out any underlying necrosis or injury or a problem. If you need deployment, you will do deployment, okay? And you will assess under general anesthesia, of course, because you can't do this while the patient is awake, of course, right? Then you will apply, right, the sutures, and you can even consider, right, closing the skin later on. But the most important thing that you manage the situation now of the burst abdomen. Okay? Is it clear, everyone? This could affect the anesthesia choice, my dear. Okay, Dr. Maria. Dr. Maria, my dear. Yes. So this patient, she is having, yes, exactly. This is what you're writing here. So would you do this with a spinal? The anesthesia, they can do some of their, some of their magic, right? Like they can give some sedation with local wound management. They can have their own way, right, to manage this patient. But for us, okay, I need to explore this patient while the patient is sleeping under anesthesia. The choice of the type of the anesthesia will be the best by the anesthetist, right? My friends, I just want to thank you very much for attending off today. And I think that I'm really satisfied with the topics that we have covered. So far, we have covered the amenorrhea and hyperandrogenism, right, with Dr. Nada, and fibroid and HMB, heavy menstrual bleeding. Also, we have done vulval ulcers, right, and adnexial masses. And here also we have post-operative complication, right? So I'm going to send you resources as I promised, inshallah, okay, in the group, in the WhatsApp group and in the Telegram group as well. Okay, so you can review it and revise it. The topics that we are revising now, my friends, inshallah, you must have, okay, these topics in the exam. If not all, at least you will find 2 to 3 topics of the topics that we have covered, right? Because in the eMRCOG, from where they will bring eMRCOG, this is your curriculum, right? So they will bring only from the curriculum and from the non-topics, from the big topics. You have to master the big topics, my friends, in your exam, right? Along with some single best answer repeated questions from the recalls, along from some questions from the TOGs, okay, you will do fine. But the most important thing that you have a good, concept and a clear understanding of the major topics, okay? Because inshallah, when you finish also part 2, you will go to the part 3 and you will find that this is the main topics in the part 3, right? So this is the core of the MRCOG exams actually, and the core of your, yes, your degree. Thank you very much, my dear friend. Thank you, Dr. Amin. Thank you very much. Thank you, Dr. Arwa. That's very kind of you. Thanks a lot, my dear. And thank you, Dr. Soha, for being here today. And Dr. Heba, Dr. Wajiha, thank you. Thank you very much, Dr. Asar. I'm happy that you are attending. And Dr. Ayan, thank you, my dear. And thank you that you have completed your homework. I'm really grateful. Thank you, Dr. Yusra, my dear. And thank you, Dr. Heba and Dr. Ken, Dr. Mohanna, Dr. Samina, and Dr. Amal, and Dr. Amasi, Dr. Marwa, mashallah, and Dr. Nazia. Thank you very much, my friend. Thank you, Dr. Adam and Dr. Khadija and Dr. Mohassan as well. Yes, Dr. Mohassan, we are having a meeting today, right, in the MRCBI. So see you there. Thank you very much, Dr. Shohanda. It has been a pleasure that you have attended the meeting. Dr. Chinozo. Is that, am I pronouncing your lovely name right? It's a very lovely name. Thank you, Dr. Samina. I love you too. I love you too, my friends. Thank you, Dr. Amina. Thank you, Dr. Parveen. Thank you. Okay, everyone, inshallah, we will have another meeting next week. Our next will be for the obstetric, right? Paper. It will be 3. And we will have another EMQ for the gynecology next week, same time, inshallah. Thank you very much. I will try my best. I'm not the one who upload, but I will try my best, my dear. Okay, I will inform the team. Thank you very much, my dear. Assalamu alaikum. Thank you, Dr. Zuni. Inshallah. Are you all in the free section on the group, in the website? If you are in the free section in the website, you will receive notification once the recording is uploaded. If you are not, then request it from the group moderator. They will add you, inshallah. Okay? Assalamu alaikum.